I will start. Welcome everyone to Chapter 2 of Treatment of Head and Neck Lymphedema. So my first question is, where's everyone from? So who's from Boston? There's quite a big Boston cohort in this group. Who's from Massachusetts but not Boston? Oh, okay. Oh, you counted yourself? Okay. And who's from another state? Okay, so good to see some people travelling. And who travelled the furthest to get here? Does anyone want to raise 26 hours? So anyway, who's working currently with people with head and neck lymphedema? And of the people who are working with people with head and neck lymphedema, who's working in a hospital where the surgery is done? And so therefore there's some of you who are seeing follow-up and long-term management of people with this condition. Great. Okay, well, this is meant to be an interactive session, so please stop me, interrupt me, and we can go through things, and there are some questions that we'll work through together as we go. So this shouldn't be news to anyone in terms of what good CDT is, but in lymphedema, I would say in terms of the maintenance phase of CDT that the most powerful tool is a well-fitted flat knit compression garment on a decongested limb, or compression bandaging to decongest a limb. You're working with a cylinder. You've got the law of Laplace to apply graduated compression. And so of all the tools, I find that actually the compression and compression garmenting in particular, because I try not to have to bandage people because we aim to manage them early so that they don't need that. It's certainly not a routine treatment, but we can do it if we need to. But it's good garments. But that obviously doesn't work in the head and neck region because we're not dealing with the cylinder and we can't get the same compression. Plus, we're dealing with someone who's been through head and neck cancer treatment. They've had to lie on that table with their face pinioned to the bed with that mask to have their radiation. And so wearing a compression garment after that, I find that it's not something that not all my patients with head and neck lymphedema would be wearing compression for 10 to 12 hours a day, which would be what I'd recommend for limb lymphedema. Is that what you guys find? I'm getting some nods there. So the other components of CDT become even more important, and I would argue that manual lymphatic drainage then becomes a really valuable tool, not just because you're doing it in a therapy session, but also then it's a tool to educate your patient in terms of self-lymphatic drainage and self-management. Their daily management of this condition is going to be so much more powerful than anything that you can do. So that's why I think that understanding the drainage patterns that we see in head and neck lymphedema and where we're actually targeting the drainage to is so important, and so important to teach your patients. We just need to be able to give them some self-management skills with this. Now, this might seem like a completely counterintuitive statement because we all think we're going to fix things as therapists, but I really do believe that lymphedema, it's the patient's best solution. It might not be great. Their lymphatic system may be really compromised. They may have really severe impairment of their lymphatic system. But this is a low-pressure driven system. If their body could move the fluid a different way, it would. The fact that it's moving it through the dermal backflow is because there aren't available lymphatic collectors. If it's diverting from an original drainage region, it's because actually the pressure gradient to take it to that compensatory region means that that's the easiest way. So I always say to my patients, particularly when I'm doing ICG with them, that this is your body's fix. This is how clever your body is at trying to problem solve this problem. And we are trying to work with the patient in terms of what they're already doing. We can't fix it. We're not creating new pathways, but that's actually a really nice message for them to hear. It's not something broken. I say the cancer treatment was the problem. The lymphedema is the solution. It might not be the best solution, but we can improve how efficiently their body's working. But so that's just my perspective on it. And I know people think I'm mad when I say, this is the solution. So, there's quite a significant symptom burden for head and neck lymphedema. And if you're working with these patients, then I'm sure that this is all familiar to you. I don't need to tell you this, but we know that there's a really high incidence of internal lymphedema when there's external lymphedema present. And sometimes there can be internal lymphedema alone, whereas the external lymphedema may not be present. One of a therapist in Australia, Claire Jeans, did a longitudinal study, and I think she found that over, I think it was a 12-month trajectory post chemoradiation, so non-surgical patients, that external lymphedema did tend to significantly improve, but the internal lymphedema remained. I wish I had great answers for what to do with internal lymphedema. As I've said, with our ICG research, we're not seeing what's happening to that drainage, but that's where your sort of fundamentals in terms of central clearance, deep breathing, movement, exercise, I've said it a million times already today, gravity, all of these things just to encourage drainage of the central lymphatics are really helpful. But what's the best way to manage internal lymphedema? I mean, you sort of see if you optimize the external lymphedema, does that help? I don't know. You're really lucky here because you have the Flexi Touch pump, the head and neck pump, and we don't have that in Australia. And it seems that potentially is a tool for use in internal lymphedema. And I've already been out to Sarah and said, please come to Australia. And she says she can't. So trismus is certainly a complication, although that's less common with IMRT now. All the cervical range of, I'd say cervical in an Australian way, sorry. I think that was distressing people. Cervical, I think is what I meant to say. But problems with neck range of movement, mobility, flexibility, strength, posture. Xerostomia is a really challenging symptom for our patients to manage, and I don't know, most of mine seem to have a little spray bottle. What do people do here? How are people managing their dry mouths here? Spray bottle? It's good to know some things aren't more high tech here. Shoulder syndrome from some of the neck dissections and radiation, and then deconditioning and fatigue is a big impact in this patient, and the impacts on body image. So, how do I actually decide what drainage region to target with my MLD? And I don't have, as I said, I don't have all the percentages. We've done a small pilot, so we don't have all the answers. The good thing about the head and neck region is it's not a big area to cover, but certainly the history in terms of what type of surgery, if they've had surgery, what was dissected, what was spared. I mean, the op report is really helpful. The pathology report is probably even more helpful. Well, that's what I find. The op report can sometimes be extremely brief, and that's if I can get hold of it, because at Macquarie, people don't actually have this surgery that's not done at Macquarie. We see people who found their way to us sort of via the internet usually, or being referred from other head and neck cancer treatment centres. Observation and palpation are really, really important for this group of people. And it's the detective fingers in terms of, is the skin indurated? You know, that pinching up of the skin where you're actually just trying to feel if the skin's full in an area, and feeling all around their neck, thinking about those drainage regions we were looking at all the way around to the back of their neck, along their jawline, the submental area, just right across the top of the larynx. So, you know, I was talking about that if there's midline edema present, if they haven't had a laryngectomy, if you just gently pinch the skin right in the top of the larynx, and even if you do it now on yourself, you should be able to feel that you can pinch it and there's just no flesh between your fingers. It's just one side of your skin pressed against the other. And if you find that that feels thickened and full, then to me, that's maybe we're getting some drainage to across the midline. Which way is it going to be draining? That's, again, part of your hypothesis from the history as far as where might be some good drainage, but it's really going to be, okay, I'm going to approach it as though it's draining from right to left. And that's what I'll write in my notes, you know, across the midline, contralateral, cervical, clavicular drainage region, right to left. And I'll do MLD and then repalpate. Get my patient to repalpate. I think your patients know the feel of their normal much better than we can. So we're constantly reassessing the whole way through a session. It's not a start and check at the end. It's a reassess, reassess, reassess. Because if I'm not making any difference, then I think I'm probably not doing anything. I've got to think of where else I might be going. What else have I got? Oh, the scar mobility also. And sometimes even deep skin folds can be quite immobile in the neck. And particularly if you see that scar where it's really pouched and thick above a dissection scar and then much thinner below the dissection scar, then I think maybe the lymph is channeling along that scar towards the drainage region, but just not going straight through it. I'll always try and mobilize the scar. So my fascial work, negative pressure, cupping, I use laser also. I think if we can get that scar as mobile as possible, then we can help. But you can actually see that it will still drain through the scar, but it might be slow and you might have to spend some time. My approach is usually sort of sustained pressure going in the straight line to the drainage region that I am hypothesizing, and continue doing that until I would expect some change. And if it doesn't change, again, I'll try a different direction. But I always aim to do the scar work and soft tissue work first before I'm doing the lymphatic drainage work. In terms of measurement, I think who has a really good and accurate way of measuring the head and neck region? What?
Point of the ear down to the angle of the mandible, then to the fold of the nose to mid-chin.
Yeah.
And then into the inner eye and the outer eye.
Yeah. So is that the MD Anderson scale? Yep. And yes, absolutely. It's just how easy is that to measure and how much change do you track? This is the challenge with these measurements. In Australia, we use the Aloha. It's not Hawaiian. So that's the assessment of lymphedema of the head and neck. And it's a validated tool that was developed by the team at the Princess Alexandria Hospital in Brisbane. And it's three measurements: an upper neck circumference, a lower neck circumference done in supine, and then an ear to ear circumference, bisecting a point underneath the chin, a fixed point. And we also do a tissue dielectric constant measure there. I think...
Sorry, is it like ear or tragus?
It's
you do
the ear, where
Okay.
the earlobe joins the head, ear to ear. And there's value. These are the measurements that I use to track progress over time. But again, with circumferences, there's a lot of factors that can change the presentation of lymphedema that are not just swelling, that will be picked up by that circumferential measurement. So I think this is what Louise was talking about with the black box assessment. You can have this measurement information, but if you're not looking at the patient and using your clinical reasoning and thinking of the history and what might be happening, then I don't think that we can get, I don't think we necessarily get value out of those assessments, but I think we need to do what we can, and absolutely that measurement tool as well is a way of trying to objectively measure the lymphedema. Are people familiar with percentage water content, the measurement tool, the lymph scanner? Has anyone heard of that? I've got a picture of it a bit later on in the presentation. So tissue dielectric constant was measuring a fluid measure in the top 2.5 millimeters of skin. And then there was a mathematical calculation for percentage water content. And that was done with a moisture meter. And before the moisture meter, there was another TDC measurement machine. These devices, I know that they are here because I saw one at Massachusetts General. But the next generation, if you like, is the lymph scanner, where the maths has been done for you. And so you hold a probe on the skin and it will give you a percentage water content. And I do use that as a measurement tool. And we do find that the higher the percentage water content, that often correlates with areas of dermal backflow. We don't have what's a normal value as opposed to what's a lymphedema, what's the threshold value at the moment. So again, more work needs doing. But in terms of trying to put together a picture in your mind, that's always what I'm trying to do, is actually work out what's the ICG chart for this person who doesn't have an ICG. Where do I think they're draining? Where's the dermal backflow? Where do I need to be applying that slow, firm massage? That's my approach. Then, of course, there's range of movement measures that I'm sure you're all familiar with, shoulder, jaw, patient-recorded outcome measures. We use the LCIDS head and neck, things like the MD Anderson Cancer Center staging scale, and also digital photography is actually quite good for head and neck cancer, but you've just always got to remember that your photos need to be taken from the same distance away from the patient at the same height, ideally with a plain background, which is sometimes hard in some clinics to actually even just get the right space to do that recording accurately. So the information from that, the history, gives me a sense of what are the drainage regions that I might be targeting. The observation and palpation helps me to make a hypothesis of the drainage patterns and where we anticipate the dermal backflow. And then the measurement is to evaluate if we've been effective. Now, I'm putting this next slide up and it's super busy. And it's on your handout, so you don't actually have to do anything with it. It's just our decision tree, a sort of summary of what I've already spoken about. So I'm not actually going to spend time here, but I understand that for the online viewers that we're going to get you a copy of the slide handout, so you will also have that. But really, it's just what I just said in terms of the presentation informs the drainage pattern, and the drainage region is informed by what type of surgery that they've had, what type of treatment. And we're still learning here. And, you know, you've just seen the early results of our pilot in terms of our thinking as far as drainage region selection. Now, these pathways I've given you, again, on your handouts, just for your reference. But remember, as a therapist, you're not going to be targeting a node, you're going to be targeting a drainage region. So you don't have to be necessarily thinking individual lymph nodes. So we've got the nasolabial, the temporal, and the submental pathway. We were quite excited by this pathway. I think this one's really interesting, and will be interesting to try and understand more about what causes that to be preserved. But so this is the things that we've found from using all our ICG learning, and this is what we're teaching our students as well, in that generally, if it's possible, then the individual will be using their original drainage region, and if that isn't working efficiently, then they'll probably use the nearest adjacent drainage regions. It's not going to be, it's a low pressure system. So as the fluid builds up in that interstitial space, it's going to drive to the nearest drainage. It's not going to go to a distant drainage region if there's somewhere near it, because why would pressure drive it that way? So, you know, it's the body's solution. It's trying to find homeostasis. It's not, we're not likely to be creating new pathways with this. We don't make the fluid go where we want. We very definitely see that directional dermal backflow. And so we haven't seen anyone sort of draining up and over the ear and behind and to the back of the neck. We see it going down. Firm, slow massage is certainly indicated with dermal backflow, but I'll temper that with saying that in the head and neck region, the pressure that I'm using is nothing like I'd be using on a thigh or a dorsal foot, because you know, the tissue is different. You don't want to be compressing really firmly over the neck. So you need to be slow, and it's pressure. It's not a sort of just brushing the surface of the skin, but it should never be uncomfortable for your patient. And I'm never applying firm pressure over the front of the neck and around the trachea. And certainly if they've got a laryngectomy, I'm not using a lot of pressure there. I might use some local sustained pressure, but relatively speaking, it's not a light brushing. If I can feel that thickness, I'm slowing down, and I'm, you know, maybe even just allowing my hand to sink in. When you hold your hand on, and if they've got that pitting edema, then you can kind of almost drift in, and then holding the pressure that allows me to sink in as I do MLD. These are just some tips based on some of the information that I've told you, and that's use both the ipsilateral and the contralateral cervical, clavicular, and paratracheal node drainage regions, particularly for that submental swelling, you know, that area which gets really firm and hard in here. Then I would be using those drainage regions for that. I've told you about the midline edema, and I use that little telltale of the palpation across the top of the larynx, or even in the submental area also. If you've got a lot of facial swelling, orbital, infraorbital swelling, facial swelling, then the submandibular nodes, and also if it's really severe, potentially going high down towards the occipital nodes. So we didn't really talk about that in our drainage pathways earlier, but the occipital nodes may be a nearest drainage region driven by gravity for the upper part of the face, but for most people, we're actually seeing a lot of the changes in that neck and submental region. That's where we're seeing all the dermal backflow generally, not through the whole face. So I think just 1 sec, we'll just so that everyone hears.
Yeah, on the deep cervical, are you finding, is that right around C6, 7? Is it near the zygapophyseal joints, or is it like?
I don't think I can give you an anatomical region at the moment. Professor Swami may give us more detail. We were literally gathering this information. I was sharing slides with him last week in terms of our understanding. So I think it's that region, but remember, when you're applying MLD, you've got your whole hand to work with, and so long as you are directional and firm, whether it's C3, C4, C5. I think you can kind of cover all of that area with a hand. So, and if you're doing firm pressure towards that area, as Robbie said, it's like a plug hole in a bath. It's going to flow where it wants to flow. So long as you're moving in that direction to the direction of that drainage region, we might be able to give you some more information, but I can't at the moment, because I think it's dropping in deep and then it's getting into the deeper lymphatics of the neck. So those cervical nodes, but deeper in the neck. And the axillary drainage, certainly if it's a severe presentation, that's that more distant drainage region, but I'd certainly consider that. If you think that that paratracheal pathway's been disrupted and it's quite severe, then I would be thinking that. But the thing about that axillary drainage region is it's actually intact collectors going towards the axilla. It's not generally dermal backflow the whole way through. So it flows anyway. And so if you're getting your patient, when you're doing your MLD, if you're getting them to do, deep breaths, shoulder circles, movement, walking, reaching, that's actually going to be working there. So you might do some work in the node basin, but with an intact collector, we can push the dye along there with a Sharpie pen, but it can also flow spontaneously, particularly when we've got gravity. I mean, with an arm, when we inject, we'll inject with the arm down by the side. And if nothing happens, we'll lift the arm up and then you just see through the collectors, the dye going through. So I think that area, I wouldn't spend a lot of time on that because this is the area that you want to be spending your time. I mean, unless you've got endless time with your patients, our appointments are an hour. And in that time, we're doing the measurement and recording all of that as well as treatment. And so, I want to be getting my hands into the things that actually make my patients feel good rather than spending all my time measuring it. And so I wouldn't necessarily spend a lot of time with working on that axillary drainage. But our approach to MLD, using this ICG guided technique, is still the way I think we were all taught MLD, in that we start with the nodes, with deep breathing, with massage of the node drainage regions. The posterior cervical, it's not that there's necessarily nodes there. Those deep entry points, we don't do like a node technique on that. The paratracheal node drainage region, it's behind the sternum. So nothing I do up here is going to make a difference, but the deep breathing, pressure change in the chest. I tell my patients, walk, get your arms swinging, get some trunk rotation, pressure change, just to encourage that drainage down. Okay. So you should expect the palpation findings to change in the session. This isn't something that you're going to do for 3 weeks before you notice a difference. And I say that to my patients. It's meant to feel different now. If I'm being effective, it's meant to feel different now. And so just assess, reassess, get your patient to reassess. But be methodical in your drainage region and sort of try and avoid the everything, everywhere, all at once. Not just because it's hard for you to know then what's effective, because obviously you can do MLD to everywhere and the bits that are being effective will be effective, but you're then unnecessarily adding to the self-lymphatic drainage burden that your patient needs to carry out. So I would start small with the drainage regions, evaluate the effectiveness. And if you're not getting the outcomes that you want, that's when I would be trying to move. So I might start with that posterior. If they've had a neck dissection, I probably would start with that posterior cervical. And then the original drainage regions, just with pressure change and deep breathing, and see what impact. But if I'm not getting any benefit, then working more with a focus on submandibular nodes.
So how many sessions would you give to see if that works, or is it just immediate they would feel it? Or
so within a session, I would expect that there's change. And what I might do is, so in a session, if I made a start and I was just working from, say, right to left towards the contralateral, cervical, cervical, clavicular, and ipsilateral, cervical clavicular nodes, then I would do that. And if I felt a change, that's all I would use, and I would teach my patient that. But when I see them, and then that's what they're doing is their daily self-management tool. If the palpation findings are not, the next time I see them, it's the same, I might actually add in posterior cervical and see what it's feeling like, them having done the previous sequence for the time in between, and see if I think that gives me a better outcome. I wish I could say there was like this real science. I think you need your detective hands. And I do find that sometimes initially I might be going across and down, but over time, as their external lymphedema improves and potentially as we've improved mobility and strength, that actually it can be a whole lot more simpler for them for their self-lymphatic drainage. But when you get the complex neck dissections, long-standing, lots of secondary tissue changes, then I think it's hard to evaluate, but that's when you are going to be using more of the pathways, but it's still in a relatively small area. So you'd look at your patient, can you realistically do that or not? And if they can't, massage this because of just the sheer act of coordinating it, and I don't have a pump to prescribe them, but you can see how the FlexiTouch pump would work when you think of the drainage regions that we're seeing. Then I would, in a session, I might change. I might decide to change. I would expect to see the change there and then. If it's working, it's going to work. I hope that answered your question, Katrina. So, meet Jeff. So you have this information here, but you're working as a lymphedema therapist in a public hospital, and Jeff has been referred by his MDT for management of his facial and neck swelling, and this is the information you get from him. So he's 62 years of age. I had to Google what 97.2 kilos was, because if someone said that they were 214 pounds, I would have no idea whether that meant they were tiny or enormous. But in any case, so he's 97.2 kilos or 214 pounds, and I hope that makes sense to you. He's 5'7", and his BMI is 33.6, and he's an Aussie bloke. So he was diagnosed with cancer of the larynx 9 months ago, and he had neoadjuvant chemoradiation, and then a total laryngectomy and modified radical neck dissection levels 2 and 3. So that's upper and middle jugular levels. So, and there's with a modified radical neck dissection, one or two more non-lymphatic structures are preserved. So the op report should tell you whether that's the spinal accessory nerve preserved or sternocleidomastoid or internal jugular vein is preserved. He had a voice prosthesis fitted at the time of surgery, and he developed lymphedema during this treatment. So he presents with swelling, tightness, heaviness and numbness around his face and neck, impaired speech, difficulty swallowing, dry mouth, difficulty breathing, and sleep disturbance and fatigue. So his symptoms improve throughout the day and movement eases the edema. Does that seem familiar to you guys in terms of this kind of population? So he reports that he smoked for 25 years but he quit 20 years ago. He's not a big drinker. And his other comorbidities are type 2 diabetes. He had his thyroid removed 5 years ago and osteoarthritis, and he's currently on BP medication, diabetes medication, and thyroxine. In terms of medical history, what are your thoughts on Jeff in terms of what are the risks that we are seeing with Jeff? Feel free to chime in. Any early thoughts on him, just with that history of risk factors for him? The smoking, yep. So he's got some risk factors for coronary artery disease because he's got a history of smoking, he's obese, he has type 2 diabetes, and then you add into that radiation of the neck region, which actually can cause stenosis, arterial stenosis. So he's certainly a risk of a thromboocclusive disease, and particularly at the carotid bifurcation. So in this area here, in the carotid triangle of the neck. And this is an area where I know in Australia, there's no routine screening of these patients in terms of what's happening with their carotid arteries, but they are at increased risk of occlusion after this surgery, and radiation significantly increases that risk. So I spoke to one of the radiation oncologists in Sydney, and he said, this is topical. We're thinking we should maybe be routinely screening these people, but it's not routine in Australia. And from my previous workshop, I understand it's also not routine here. But certainly the guidelines that I've been able to find are if they have unmanaged risk factors, other unmanaged risk factors, then they're really highly at risk of a stroke. So it's worth thinking about in terms of your management of these people and avoiding very firm pressure right over that carotid triangle area, unless you've excluded that disease. So that's ultrasound or CT angio. So just something to think about with a patient with a history like Jeff. Okay. He's married, no children. He has a supportive partner and they live in a city apartment. He runs his own investment company. He's currently not working. He was very socially active and he was physically active, and he now reports he's walking and performing physio exercises for 20 minutes, 7 days a week. So what do you think about his activity level? Sorry.
7 days a week is pretty good.
7 days a week of 20 minutes is 140 minutes. So what are we aiming for with our post-cap? Yeah, 150 moderate intensity. Physio exercises, I'm a physio, I'm biased. Sometimes I don't know that they're necessarily moderate intensity. The exercise that you can talk and do, but not sing and do. So I think some of them might be, if he's just doing shin tucks, a little bit of side flexion. So he's probably not doing enough exercise, and and within that, if he's also not doing resistance exercise, so maybe there's some room for improvement with Jeff there. Oh. Sorry, I've got two things working here. He's anxious, depressed regarding his appearance. He wants to reduce the swelling, minimize his facial disfigurement, and he'd like to return to work part-time, get back working in his business, and also get back to travel. So those are his goals. So he's got a very altered appearance with visible edema on the face. I'm going to go through some of this quickly so we've got a time to talk. And also visible edema of the neck with the surgical scars are apparent, with skin pouching above the scars bilaterally. And there's also visible edema above the stoma. The buccal mucosa appears thickened, but there's no visible tongue swelling. He has soft pitting edema on the right and left side of his face, firm in the neck, and you're unable to raise the skin around the whole neck. It's indurated and you can't pinch it up over the midline of the neck, and the scar is adherent, particularly on the left side of the neck, with reduced fascial glide through range. I think with scar assessment, you put your hands on and you feel the glide in every direction, but then actually get your patient to move and feel the glide through movement. Because sometimes what feels really mobile in neutral will just completely lock up. And I'm sure you've all felt that. So this is my lymph scanner measuring percentage water content. And this is the points that we record this. It's a very quick measure. The challenge we have with the lymph scanner at the moment is there's no sort of published what's normal for the head and neck. My impression just from using it a lot is a sort of 30 to 40 seems to be normal, but so elevated is, high 40s, 50s. I've seen 70s in the head and neck region. So that's as a percentage of water. But I do find, as I said, this correlates with areas of dermal backflow. And we can see that it's elevated in the right side of his face, all the way down the right side of his face, and the upper neck, not so much in the lower part of his neck. There is some in the submental region and slightly less on the left-hand side. For those of you who haven't seen it, that's what a lymph scanner looks like. So it's just a little handheld probe. You hold it on the skin, press start, and it will tell you if you're putting too much pressure or not enough pressure. So just hold it there and it will do a percentage, give you a number. We aim to do 3 and take a mean of that at each of those points. So it's quite a quick reassessment tool, and I like to sort of track that over time with patients. So this is the aloha that I said. So lower neck, upper neck, and the length from ear to here. So this measurement as a standalone means absolutely nothing. It's only when you track over time that you can get any value with circumferential measurements in the head and neck region. But you're also having to factor in, over their treatment, if they had a PEG tube for feeding because of the radiation changes that stop them swallowing, then they've lost weight. And so they start off with their neck quite scrawny, and as they recover, if they increase their weight, then their neck circumference can increase, but it's not necessarily an increase in edema. So again, putting the percentage water content, the palpation findings, the circumferences together with tracking body weight, that's how you're going to have to try and understand what's going on here. So his body composition measures here are total body weight, fat-free mass, skeletal mass, muscle mass, and fat mass. I actually use, these are taken on the SOZO. So who uses a SOZO? Okay, so I mean, this is, the wonders of technology. I do find that tracking these body composition measures are really helpful in this head and neck population. The SOZO has traditionally been used for the LDEX, for the lymphedema index, but we can look at these body composition measures, and just for your reference, if I can find it here. So skeletal muscle mass, so he's 28.6% muscle. So a healthy range for a male is greater than 35% muscle, and extremely low for a male is less than 27% muscle. That can mean possible sarcopenia. So Jeff's pretty low in muscle mass. Fat mass, healthy for males. I mean, it's a big range because as you age, it increases. But for males, it's 8 to 24% fat. So Jeff's 35.7% fat. Now, these patients often, during their treatment, as I said, they've lost weight. And so they lose fat and they lose muscle because they're not doing anything. So they're deconditioned, they're tired, then they can't eat. And then as they recover, they do start to gain weight. What do you think they gain? Fat. Yeah, because if they're not doing resistance exercise, the power of 20 minutes, 7 days a week, is that going to be enough for Jeff to actually build muscle? If they've got trismus and they can't eat, chew food, maybe does that mean that they're not eating meat and their protein in their diet has reduced and they're having more high calorie alternatives so that they're gaining weight but not necessarily building muscle? All of these things impact the whole of Jeff and his lymphedema. So that's one of the reasons why I like to measure body composition and track it, because it gives us some teachable moments in terms of changes that can improve lymphedema. We know that people who exercise, we see their lymphatics move really efficiently. We know that the mortality and morbidity rate for cancer is significantly improved by meeting those exercise guidelines, the 150 minutes and 2 to 3 resistance sections, and improved even more by exceeding the guidelines. So that's certainly something to be working on with Jeff. How are we going for time? Right, galloping. So range of movement in the neck, you can see it's quite restricted. Now, if we think about those drainage regions and the drainage through this area, he's got 4 degrees of side flexion each side, and that rotation is also 14 and 17 degrees. So addressing that can actually help to improve his lymphatic drainage. If you think about where those lymphatic vessels lie, you saw how it moves through that area. If the whole area is not moving, that's not going to be optimizing his own normal lymphatic drainage. So get these people moving and regain the range, because actually that's part of your lymphatic management as well as just his recovery. His shoulder, I guess he didn't lose his spinal accessory nerve because he's got pretty good range there. He has a little bit of trismus, so less than 35 mils is classified as trismus, but in saying that, it's 32, so it's not terrible. But has that impacted his diet? Has that impacted his ability to clean his own teeth and perform oral hygiene? And you know, is that one of the factors that he's dealing with? So this is the information we get from the measurements. The number means nothing unless you're understanding the impact in Jeff's life. So here's where you guys do the work now. So what are the red flags for Jeff and other causes of edema for Jeff? So Katrina's got the mic and she can take it around if anyone has a suggestion of what are the red flags that you would think for Jeff. What things would you be concerned about? We already spoke about one, which was the risk of occlusive arterial disease. So that's certainly something to keep in your mind. Anything else? Absolutely, always. It's always should be first on our list. I mean, he's not far down the track, but if you're seeing someone in an outpatient session who presents exactly like this, but 3 years down the track, when we last reviewed by your med-onc team, and if they haven't been, we can't exclude it. So I think that always needs to be in your brain. Any other? Yep, absolutely. His BMI and then those body composition measurements, like he's nearly sarcopenic. So, yep. And I mean, I think those are the main things. The other thing is, you know, we always talk about cellulitis with lower limbs and upper limbs, the risk of cellulitis, and we always want to exclude that in terms of our red flags if we're managing someone with a flare-up. Now, that's not Jeff's history, but remember in this patient population, intraoral infection, oral hygiene, that's a pathway in for pathogens. If they've got inflamed gums because they can't clean their teeth because they can't open their mouth, then that can be a risk for exacerbation of their lymphedema. That can be what triggers the episode of cellulitis that then causes more damage to their lymphatics. So that's always something to to think about and also educate about. I know when I teach head and neck lymphedema in Australia, and we now have speech pathologists who can train to be CLTs in the head and neck region, and I've learned so much from them, but bicarb soda mouthwashes is one of the things that they said to me in terms of that oral hygiene to keep an alkaline environment for this post-radiation group, but and sometimes even having to use little pediatric like gum cleaning tools if they can't get their toothbrush in their mouth because of trismus. So something to think about. Now, you guys now know this. What are the likely compensatory drainage regions for Jeff? Katrina's got the mic. She might even answer.
The posterior cervical.
Yep, absolutely. It's certainly one that I'd be thinking about. We saw that elevated PWC in this area too, so that would be one of my thoughts. What other drainage regions? Remember the original ones? Maybe crossing the midline. Do we think he might be crossing the midline? There was certainly, we couldn't pinch the skin. It felt full and indurated. So yeah, potentially crossing the midline. Axillary. Yep, potentially. Absolutely. So I think that's the thinking that we have to start with in terms of what's going to happen with this man. So what sort of compression, oh, hang on, no, let's go back. What other factors would be addressed in his management from the history that we've had? What else do we need to work on apart from just selecting a drainage region and doing MLD?
Range of motion.
Yeah, absolutely. Range of motion of the cervical spine. What else? Trismus. Yep. What else? Absolutely. Strengthening. And think, the posture that you see, that sort of round-shouldered, short pecs, tight upper traps, short sternocleidomastoid. Postural correction is often important. Spinal accessory nerve strengthening. Certainly, I mean, we've done he's a 175, so he's got full range, but I'd always be assessing standing behind and looking at the scapular biomechanics in terms of what's happening. Yep. Interesting question. And I'll just say the question just because it won't be on the mic. So do I specifically give a deep neck flexor exercise? So we've discussed that. What do we do for internal lymphedema? I use laser because I can apply the low-level laser on the outside and it's got a penetration depth of 2 centimeters. So I feel I potentially can get in with the low-level laser. But I actually think that training the deep cervical neck flexors, longus coli, longus capitis, those ones, that we know that we can actually build muscle bulk in those muscles because that's been demonstrated on ultrasound that specific training of the deep neck flexors can actually increase the bulk of those deep neck flexors. And that posture that we see in head and neck lymphedema is also a position which is chronic neck pain. And we know in chronic neck pain, we can strengthen the deep neck flexors and it does actually improve their symptoms. And I also inherently think, we're wanting pumping and pressure change in the neck. So potentially if we improve the deep neck flexor strength, maybe that's a way that we can modify that internal lymphedema symptoms. I don't have any evidence for that at all, but that's my current thinking.
So I think we should think about thoracic mobility because the head's not going to change. Postural is not going to change until you get thoracic mobility back.
Absolutely.
So one of my favorite exercises is to give these patients the foam roll across the sort of the bra strap area, hands behind the head, knees bent. They don't have to open their arms as much as they, are comfortable with doing, and just having them hinge 4 levels, 5 repetitions, and that starts to improve thoracic mobility, because we're never going to do deep neck flexor exercises and have it be maintained, or postural changes, if they don't have the thoracic mobility to go with it. So I'll start my patients on that really, really early. In fact, anybody that sits in front of a computer should do that, just for good riddance. But
no, thanks, Leslie. I think that's a really good suggestion. And it's looking at the whole of Jeff and his posture. And so movement. I know there's some research, the Mantle trial done here with speech pathology and physio in terms of myofascial release, range of movement of the neck, thoracic spine, strengthening to improve dysphagia post head and neck cancer, because you can't swallow. If you've tried swallowing in a slouchy position, it's really difficult. So if you're in an upright position, you actually improve your swallow. And so to try and improve some of that internal structure. If we keep people swallowing and moving through their radiation treatment, that seems to help their internal lymphedema. So I do think inherently movement is what we want. So posture, deep cervical flexors, these are
breathing.
the things
So
that we
if they
want.
don't have thoracic motion, they're never going to be able to lower their anterior ribs. So I pay a lot of attention to patients' breathing and can they move their rib cage. And I'll probably go over this a little bit tomorrow, but one of my favorite things is to have them blow up balloons, because just having them blow up balloons, the big ones. Well, I have a bunch of balloons.
And the speech pathologists call that expiratory muscle strength training. But
it's also rib flexibility.
Getting
rib
all of
flexibility,
that. All of that. It's movement though. It's movement because the lymphatic system is a low pressure system. And if we can get pressure change in the chest, potentially we can improve. Okay. So again, just a few tips. Start simple. Use gravity. I always do this treatment with my patients sitting upright and work on the scar first. And I do quite a lot of scar mobility work using negative pressure, cupping, laser, kinesio tape. Really like kinesio tape for these patients. I think there's a picture in your handouts. And also teaching self-lymphatic drainage. Compression garments, what are you going to think about with your compression garment? Any thoughts? Yeah. I think we see the dermal backflow in the submental and neck area predominantly. So that's the area that I think you can target, and texture in compression. Remember, we don't have a cylinder. We can't work with Laplace's law, but if you can get some texture, and we use Mobiderm, which is a small chip. It's like a chip bag, but with quite small chips, and it's nice and flexible in underneath that submental neck compression. I think be wary about who you put into a full face mask. It's certainly not where I would start with anyone, because having tried them on, they're really, really quite intimidating to wear. And anyone who's already been through radiation treatment and then you're asking them to put on that mask, it's a very big ask, and I don't know what sort of compliance you get. I certainly, having tried on all of these garments, I'm very, very gentle in my introduction in terms of start with half an hour. If you can tolerate it, build it up. Aim for 1 to 4 hours a day. Use texture under your compression garment for half an hour before you do your self-lymphatic drainage, and move around while you're doing that. Do some other exercises, do your thoracic exercises, but with the texture and the garment on. But it's not something that I find that I can get people to wear for hours on end. They just don't tolerate it. And I don't blame them, because I've tried them on. So that's my little kinesio tape. Do we need to?
We have a question.
Some questions.
Yep.
Would you avoid MLD and compression for a patient high risk for carotid stenosis?
Yeah. The trouble is there's no data. I certainly think I wouldn't be doing firm pressure over that carotid triangle if I hadn't excluded it. But in saying that, I still would be quite happy to be going towards the posterior cervical deep entry. I would be happy to be doing active movement, I would be working submentally, and I would be working potentially on fascial range of movement. But yeah, I think you need to be aware of it. Is it an absolute contraindication? It's really hard because there's just no information. And as I said, there's also no routine screening at the moment. So there's some research to be done.
There are a few comments about xerostomia. I guess acupuncture
Yep,
has been shown to help.
absolutely. I think that
And
and
then
laser can potentially help.
Someone else said herbally prickly ash tincture on tongue for dry mouth. And then there's another question, approximate cost for the lymph scanner.
You'd have to ask my boss because I didn't pay for it. And also I'm talking Aussie dollars. So it's Delphin is the company that makes it. They're actually Finnish. Are they Finnish? I think they are. Yeah. Yeah, Delphin. But I'm sorry, I don't have information on that here, but I'm sure you could Google it.
One of our clinics has a low level laser, and one of the contraindications is listed as previous cancer, but I don't know
I know.
how you feel about that.
Look, there is
Yeah.
the Walt position paper, the World Association of Laser Therapy, 2022, laser in head and neck cancer, and it goes through oral mucositis, lymphedema, like all the different sort of potential consequences of head and neck cancer, and it gives dose guidelines and recommendations. Most of them have currently there's not enough evidence. However, Walt recommends this dose for this frequency at this time. So there is certainly evidence supporting it. And I know that contraindication of cancer, but that's not my understanding.
Although the RIANCorp laser has been FDA cleared in the United States for treatment of lymphedema, which is around cancer.
Yeah, and so the RIANCorp, which is the little handheld laser,
I have one. I'll bring it tomorrow.
I use that. I'll have one hand doing MLD and one hand doing laser. That sometimes takes a bit of coordination. I tend to use that RIANCorp for head and neck because it's just a smaller area that I'm trying to cover. But I do use laser, but I really like kinesio tape. But with the kinesio tape, I'm thinking, where's the drainage region? So here, it's clavicular, cervical drainage region is my anchor point. I always tension it to apply. I mean, not the tape, but actually tension the skin by getting the patient to turn as far as possible and then put it on. And then it's just really a subjective assessment, but I find that that's kind of helpful. You don't have these here. This is a Comfy Wave. It's my favorite sort of textured night garment for arms and legs. And this is the prototype for the head and neck region, which I think looks like a big balaclava. It's actually texture, and it's texture in that submental and jaw area. So I just put it there because I didn't know you didn't have Comfy Waves when I put it in. Sorry? How much compression? They're only class 1 compression. It's all about the texture. It's not about the compression, but they're quite comfy. They're not actually, that's the prototype I snapped. That's the managing director of Haddenham UK who came to New Zealand to our conference. And I said, can I please take a photo of you in that? So he did agree. He looks doubtful, but he did agree. But this is the sort of style of compression that I use.
So the other groups are finishing up. So I wondered if you wanted to wrap up or ask for some final questions before we reconvene with the rest of the groups. Any final questions? Or any final comments?
No, just thank you for having me, Kathy.
Thank you. Very much appreciate all your expertise. Thank you.